Welcome to the USF Health Library's microlearning session on experimental study designs. This microlearning session answers the question, what is an RCT? We will learn the difference between an observational study and an experimental study, the differences between types of RCTs, and look at common issues that are important to identify when examining RCTs. When evaluating interventions, efficacy and effectiveness studies are both important. However, they serve distinct purposes and have different study designs. As you can see from this chart, RCTs are preferred for treatment efficacy studies, which examine the performance of an intervention or treatment under ideal and controlled circumstances. The first question to ask is there an intervention in the study? If the answer is yes, then the study is experimental. In an experimental study, the investigator creates a controlled trial at the patient or population level to determine the exposure to a disease or disorder and tracks the participants over time to detect the effects of the exposure. RCT has become the umbrella term for an experimental study. However, technically speaking, there are two experimental study types, the Pragmatic clinical trial and the explanatory RCT. Think of these study types as on the experimental study continuum. Pragmatic clinical trials determine the effectiveness of specific interventions or available medicines as it occurs in routine clinical practice. The question it answers is, how does this intervention work under usual conditions? Explanatory RCTs determine the efficacy of a clinical intervention under optimal circumstances. The question it answers is, how does this intervention work under ideal conditions? For more about the differences between PCTs and RCTs, see this chapter from the NIH Pragmatic Trials Collaboratory. While both PCTs and explanatory RCTs are experimental controlled studies, RCTs have the highest level of methodological rigor in their study design. To reduce bias and establish a high level of evidence in the study outcomes, RCTs control as many variables as possible in their study design, using random assignation, blinding, and pre-specified primary and secondary outcomes. Study participants are randomly assigned to either an intervention or control group. Blinding or allocation concealment ensures none of the researchers or providers or patients know which participants are receiving either the treatment intervention or the control intervention. RCTs also have pre-specified primary and secondary outcomes, using objective measures to ensure confidence in the results and to reduce bias. Crossover designs are most appropriate to study treatments for stable and chronic diseases. All participants receive the same number of treatments, usually in different sequences over time. Because the patients act as their own controls, between and within group comparisons can be made. Cluster RCTs are studies in which patients are grouped into a cluster based on the geography of practice, such as caregivers, clinical settings, communities, and then randomized as a group to either an intervention or a control arm. Useful for measuring an intervention on a large scale, cluster RCTs may also examine how natural variations in practice patterns affect the comparative effectiveness of patient therapies. Delayed start or randomized start designs determine whether an intervention acts by reducing symptoms or by modifying a disease. Good for slowly progressing diseases, such as Parkinson's, delayed start designs provide a clinical endpoint that reliably measures disease progression and reduces confounding that could be caused by the study's intervention effects on the symptoms. Less common are N of 1 RCTs, which are RCTs individualized for a single patient. Clinicians may choose an N of 1 trial when there are therapeutic uncertainties for a specific patient. Hence, N of 1 RCT treatment decisions are based on objective data as well as patient-centered outcomes. When examining the relationship between an explanatory factor and an outcome, it is critical to identify study design issues. This slide is just a very short list, not in rank order, of possible problems in the design of experimental studies. They range from poor selection of endpoints, inappropriate subject selection criteria, to inadequate randomization, stratification, and blinding, to non-clinically relevant or feasible treatment intervention regimens, oftentimes compounded with the failure to use intention-to-treat analysis, or insufficient sample size and power. Any study design has strengths and weaknesses. Crossover studies are especially useful when effects of treatments are brief and reversible. Only small differences exist between the new treatment and the standard one, and the effects are very similar. However, the design of the washout periods between treatments may be problematic. and responses to treatment are correlated, not independent. Cluster studies are useful to measure the effectiveness of an intervention on a large scale and are good designs for comparative effectiveness studies. They also may avoid weakening the estimated treatment effect. However, since cluster studies use intra-cluster correlation, it can be difficult to obtain statistical power equivalent to that of individual randomization designs. Delayed start studies are useful when there is a need for prolonged study duration or to determine whether an intervention acts by reducing symptoms or by modifying disease. Delayed start study designs could be a useful strategy to evaluate staggered implementation of policy changes, such as outcomes associated with insurance or coverage restrictions to treatment. However, delayed start studies can be problematic. They require an in-depth understanding of the clinical progression of a disease and a strong statistical and analytical background for the researcher. N of 1 studies should be conducted when the disease state is stable and carryover effects are considered absent or negligible. N of 1 trials become increasingly less feasible to conduct as more time is required to observe treatment effects. PCTs are useful because they show usual practice real-world results and focus on the effectiveness of an intervention. One significant limitation of PCTs is they may or may not have used randomization, or they use samples of convenience. There are also more design and analysis challenges in PCTs due to the potential heterogeneity of treatment effect. When examining the relationship between an explanatory factor and an outcome, it is critical to identify elements or factors that may modify the outcome or create misleading associations. 4 of the most common errors are biases, confounding factors, effect modifiers, and random errors. Bias is a systematic error which is in design, conduct, or analysis of a study that results in a mistaken estimate of an exposure's effect on an outcome. Confounding occurs when a measure of association or relationship between exposure and outcome is distorted by the presence of another variable. This may cause over or underestimation of the true effect affecting causality. Effect modification occurs when a variable differentially, positively or negatively, modifies the observed effect of a risk factor on disease status. Random error occurs when a false association between the exposure and disease arises from chance with no assignable cause. While bias, confounding, effect modification, and random error are far more complicated than we want to cover in this presentation, consider these simple if questions. If the method used to select subjects or collect data results in an incorrect association, then you have bias. If a different variable is associated with both the potential risk factor and the outcome, but it is not a causal factor, there is probably effect modification. If an effect is real, but the magnitude of the effect is different for different groups of individuals, for example, males versus females, you may have confounding. If a false association between the exposure and disease arises from chance with no assignable cause, then there may be random error. There are a number of tools available to help learn more about methodological rigor needed for experimental studies and how to appraise experimental studies. One of the best resources in the USF libraries for researchers at any level is the SAGE Research Methods Collection. The collection has a multidisciplinary approach covering methods commonly used in the social and behavioral sciences, medicine and health, technology, science, and the humanities. It has books, reference books, journal articles, instructional videos, and podcasts that provide context for any part of the research process, from writing a research question to choosing a research method, collecting and analyzing data, and writing up the findings. Of especial interest may be the Little Green Books series, which focuses on all things quantitative, as well as the Methods Map and Project Planner. The Methods Map can help you choose the right study design for your project, and the Project Planner helps you plan all the steps necessary to conduct your research project. Here is a selected list of appraisal tools for RCTs that may be of interest as you delve deeper into the experimental study design. There are appraisal tools also developed by different professional associations that may also be of value. And the research and methodological rigor continues, as shown by this study by Schendelmeyer et al., who identified 36 criteria to assess effect modification claims and RCTs. Thank you for joining us today for this microlearning session on experimental study designs. If you are interested in our other microlearning sessions or research and reference resources, Check out our website at libraries.health.usf.edu, our YouTube channel, USF Health Libraries, or email us at healthlibrariesresearch@usf.edu. Keep in touch with us for more research tips and tools.